Just one disclosure, I do some consulting with Community Health Focus, which is a patient advocacy group that is involved in education. I'd like to share with you a recent survey that was done here in the state of Michigan with primary care physicians across the state, largely on the western side, mid and southern Michigan. The sample size was around 250 or so. And it was based in response to this article that I'm presenting right now, in that even though we have a lot of folks who have chronic pain, our primary care physicians don't receive a whole lot of education in pain. So I'm glad you're all here this morning. 80% of American medical schools have no formal pain education. And those that do usually have 5 or fewer hours. And those 5 or fewer hours are usually biological or cellular based, physiology. It's not kind of the interpersonal types of things that we're talking about here today. Only 34% of physicians reported feeling comfortable treating chronic pain, and only 1% found it a satisfying focus of their practice. So the survey that we sent out here in the state of Michigan found that 34% of primary care treating physicians no longer accept new patients with chronic pain. So even though we have a situation where we have more people than ever with chronic pain, there are a number of practices that are not accepting new chronic pain patients. 79% currently prescribe opioids for chronic pain, and 72% of physicians lacked alternative treatments to opioids. If you ask them, what would you like to know more about, they did want to find options other than opioids for treating chronic pain. They needed more information about how to wean people from opioids, and they wanted to know how to find substance use, behavioral health, and pain management in their communities, and most important, how to get them paid for. So this is kind of the state. The primary care physicians are the ones on the front lines, and they are asking for more information about how to treat chronic pain using things other than opioids, and needing more education. Well, we do know that there are some alternatives to opioids. They may not be in the hands of the treating physicians right now, but if you look at the data, there's the strongest evidence for educating patients about pain, for using aerobic exercise for pain, and cognitive behavioral therapy. And that's what I'm going to be talking about today, is cognitive behavioral therapy. So what is cognitive behavioral therapy? Well, it's kind of a generic term. It's kind of like the term surgery. Surgery refers to a lot of different procedures with a lot of different tools. It takes different training to do different types of surgeries. Well, cognitive behavioral therapy is kind of the same thing. It's a generic term that can be applied in a lot of different settings. It had its origin in mental illnesses, and there were cognitive behavioral therapies developed specifically for depression, OCD, phobia, and anxiety. But more recently, in the field of behavioral medicine, they've developed cognitive behavioral therapies that can be used in the context of cardiovascular disease, diabetes, asthma, cancer, chronic pain, and we've done some work specifically in fibromyalgia. The skills that are applied in cognitive behavioral therapy can vary widely depending upon what the target is. But what they do have in common, just like surgery, usually you're going to cut something. Well, in cognitive behavioral therapy, it's based on the idea that you're going to be changing cognition and you're going to be changing behavior to improve health. So it's usually a method that's used for identifying and modifying behavior and thinking patterns. And why do you need a therapist for this? Well, because people will many times learn a bad habit, or they learn to adapt to a situation. For example, if you have an acute injury, you might just learn that it feels better when you lay down or you withdraw from social situations, or you don't do as much, or you rest more, or whatever. And so you learn that. And so you're likely to carry that from an acute stage into a chronic stage. Well, of course, we know that resting a lot, withdrawing socially, staying away from work, those types of things are exactly the wrong thing to do for chronic pain. And so many times you have to have a coach or a therapist or somebody working with you to help you learn a new pattern of behavior, a new pattern of thinking that's different than what was adaptive for acute pain, but now is maladaptive for chronic pain. So when you have cognitive behavioral therapy, there's two people involved. There's the patient, and the patient identifies the problems, they define the goals, they learn the skills and implement the solutions. And the therapist largely listens and hears the story, understands the individual, and can personalize the skills and help the individual overcome some of the barriers they might experience as they try to make these new behavioral changes and implement them in their lives. So I'm going to ask you to think a little differently about chronic pain. And these are some of the things that we work with when we talk with patients. The first thing, and this was a point that was mentioned yesterday, but I'm going to really drive it home, and I hope it's a take-home message for you as you leave here today. Damaged tissue and pain are not the same thing. Another way of saying this is that nociception and pain are not the same thing. They're correlated. They're often correlated, and they travel together. But sometimes they don't travel together. You can have nociception without having pain, and vice versa. You can have pain when there's very little evidence in the body of something being broken or injured. You know, the slide that you saw first thing yesterday morning of the two knees is a good example of the idea that nociception and pain, while correlated, don't necessarily occur together. A good example of this was in the news recently. The young fellow that you see in the picture there, he's a surfer, and his leg was bitten by a shark. And what he says is that I wasn't feeling the bite, and I thought I've got to get to shore. So here's someone who had an injury. His leg was bitten by a shark. You would think that would hurt, but he reports having no pain. He was just focused on trying to survive and get back to shore. So here's a good example of where an injury is not associated with pain, even though in some people it would be, or in other situations it would be. Pain is always processed in the brain. It's something the brain produces for you. It interprets the nociception and provides the experience. It's very important to think of those things as two different occurrences. So pain is a perceptual experience, and we probably need to think of pain like other perceptions of the body. Our body does have a number of perceptions where it uses biological reference to give information about that perception. But again, it's very different than the experience itself. Hunger is a good example. Usually when our stomachs are emptying, we feel hunger. But of course, yesterday was a good example where we had just had lunch, but then when they brought the snacks out, we went ahead and ate them anyway. You don't necessarily have to have a shrinking, your stomach being empty in order to experience the perception of hunger. Itch and tickle are other examples, and probably the one that we're studying most right now through the MAP network and with NIDDK is urinary urgency. I'm sure you've all experienced, usually when your bladder fills, you experience urgency, and those two are well correlated. But they don't have to be. Sometimes your bladder may only be partially full, but the urgency is there. Or you may have noticed that when you feel a little bit of urgency, but the closer you get to the bathroom, the urgency becomes more intense. Well, your bladder's not filling faster. It's a perceptual experience your brain is creating, and pain is the same way. So what I would encourage you to think about is, rather than always trying to fix the damage or trying to fix the injury, and this is what most of our interventions have tried to do up till now, is you fix the injury and the pain is supposed to go away. Well, maybe our interventions need to be targeting not fixing the injury, our interventions need to be fixing the perception. And so we need to have interventions that focus more on how we fix the perception so that we're experiencing less pain, because that's where the pain is being generated. And cognitive behavioral therapy, focusing on behavior and thinking, is a good example of an intervention that's not trying to fix the damage, it's trying to fix the perception. So that's kind of the rationale for why we would be using cognitive behavioral therapy in the context of pain. So you saw this slide yesterday. This shows all the different neurotransmitters that are involved in pain perception. And these neurotransmitters are also the foundation for the various drug interventions for pain. Well, these neurotransmitters play other functions. These neurotransmitters also are associated with concentration, circadian rhythm, attention, and stress, and energy. Serotonin is associated with well-being, sleep, and appetite. Dopamine is associated with attention and pleasure. Glutamate, which we heard a lot about yesterday, is a major exciter of the central nervous system. And GABA is a major inhibitor and also involved in the sleep and wake cycle. So all these are processing pain, but look at all the other things that they're involved in. So when your patient walks in complaining of pain, they probably also are complaining of some other things. And so we tend to think of pain patients as very complex patients because they have all these other things going on. But what are the things that are going on? Well, the most common things that are going on are sleep problems, widespread pain, mood problems or affect problems, cognition, poor thinking, fibrofog, things like that, and fatigue or lack of energy. This spells out space, and we'll refer to this again in future slides. But what's good here is that whereas our drugs for pain may not be optimal right now, but we do have pretty good interventions for sleep. And so if we can intervene on sleep, then we may be able to also affect the pain because they're sharing the same neurotransmitters. Same thing with affect. We have fairly good interventions for mood. Maybe we focus on the mood or we target the mood and indirectly hit pain. Same thing for cognition, same thing for energy. So the good news here is that whereas we don't have real good drugs for pain, we do have fairly good interventions for the other parts of space. And so we may be able to hit pain indirectly. And so rather than saying, well, there's nothing in my black bag for your pain, you actually have a lot in your black bag that can indirectly hit pain if you think about this symptom cluster that shares neurotransmitters. So you have a lot of new targets now for pain treatment. So what's the doctor to do? Well, we get a lot of guidance from the federal government right now, and they're all saying the same thing. They're all saying self-management, evidence-based, patient-centric interventions, multimodal pain care is the way to go. And we saw this yesterday in the slides where we're looking at the CDC guidelines, where it was talking about non-pharmacological approaches needing to be the front line of interventions. This same message is in the Institute of Medicine's report, Relieving Pain in America. The National Pain Strategy calls for more use of self-management. Healthy People 2020 also focusing on self-management and non-pharmacological interventions. The Federal Pain Research Strategy, which came out a couple of years ago, which is kind of a blueprint for what research should be done in the field of chronic pain, also focusing a lot on self-management, patient-centric work, and of course the HEAL initiative coming out, all the money coming for grant and research in pain, some of those things focusing, some of those RFAs focusing on non-pharmacological interventions. We also saw this yesterday. This is the VA's step care model. Notice the step one is not drugs or surgery. Step one is self-management. It's doing the things that can attack that space concept. This is the pain care pathway from the UK in the National Health System. Notice in this pathway it starts with diagnosis, then has a multidimensional needs assessment where you identify goals and treatment planning. And then what's the first thing you do? Education and self-management. Again, education and self-management being at that first step, then moving on down to cognitive behavioral therapy or interventions that are professionally driven or needing a licensed practitioner. So I'm going to focus on the self-management and the CBT, and these two things actually are very, very similar. Many of the concepts we use, the behavior change we're looking for in self-management, can be done on your own. Sometimes it helps to have a therapist involved or a coach, or we've done some studies recently where we've taken self-management and we've had psychologists help. We've also had physical therapists help. We've had occupational therapists help as coaches, nurses. We've used a lot of different professionals to help use these self-management approaches to help people get them into their lifestyle. So how do you erase the space concept? Erase stands for emotions, reflections, actions, sleep, and environment. And so these are kind of the various elements where you would have techniques that can be in a self-management perspective or can be in a cognitive behavioral therapy environment. The first one's emotions. And so you can alter a pain perception by altering affect. And 3 good ways of doing that. On a purely behavioral basis and the self-management base, you can use pleasant activity scheduling, where basically you just help individuals get more pleasant things into their lives. It sounds simple, but it's amazing how little enjoyment people with chronic pain have on a daily basis. And you help them just have an improvement in their life on every day. Emotional awareness and expression therapy is a new intervention where it takes a look at trapped affect that may be driving part of the pain problem. And it uses either an individual or a group-based environment. It's similar to cognitive behavioral therapy, has many of the elements of cognitive behavioral therapy, but focuses a lot on getting trapped affect out and resolved. The intervention many times is very effective for people who do have a trauma history, where some of the trauma or some of the affect associated with an early trauma is trapped and contributing to some of the perception of pain that the individual is experiencing. And traditional psychotherapy can help as well. It's important to notice that patients do not need to be mentally ill to have chronic pain. I remember many years ago as a psychologist working in a pain service, the only referrals I would get initially was, fix the emotional disorder so we can work on the pain. And while we do have cognitive behavioral therapy for depression and anxiety, we also have the ability to work on behavioral strategies that can help with pain as well. And so you don't always have to be treating a mental illness just because somebody has chronic pain. And the old notion that if our drugs don't work, then they must be mentally ill, and that's just not accurate. There are stands for reflections. This is using cognition to alter pain perception. The big intervention here that's usually found in cognitive behavioral therapy is cognitive restructuring or reframing. Again, this is the idea that when you have pain, it's natural to feel that life is not going well for you. However, it's important to take a look at those cognitions, because when you're thinking negatively, that obviously leads to negative emotions, and negative emotions lead to more perceptions of pain. And so helping people think differently, and we're not telling people to just bliss out, that's not the message. Obviously, it's realistic reframing that can be helpful in terms of dealing with everyday life. This is where the attacking of things like catastrophizing plays a role. But basically having people reinterpret the situations they're in to a more realistic idea, and that pain doesn't have to be a central component of someone's life. The R can also stand for relaxation, and relaxation is one technique that can be very helpful for musculoskeletal pain. It's also helpful for stress reduction, and we find that folks can use progressive muscle relaxation, which is tensing and relaxing various parts of the body. Yoga works, visual imagery works, meditation, mindfulness, and biofeedback are all vehicles for helping folks with a relaxation response. Which one works the best for chronic pain? They all work. The data supports all of them. The one that works best is the one your patient is willing to engage in on a regular basis and do regularly. There is some data suggesting that you really have to know your patient, because some individuals that find biofeedback helpful, that like to be hooked up to a computer and have instant feedback as to whether they're relaxing or not, may not be the same person that gets into mindfulness. The A stands for actions, and there's many behaviors that can be done to help with pain. Exercise is the number one change that can be helpful. Exercise hits almost every element of the space symptom complex. We know exercise is good even if you don't have pain, but it's certainly good as a foundation for individuals who have pain. Now, while it's probably one of the most powerful behavioral strategy and self-management strategy that we have, it's also incredibly difficult to get people to start exercising. And one method that has been helpful in doing this is using lifestyle physical activity. And this is a joke, but the idea that when you say, I want you to exercise, people will say, oh, I can't possibly exercise because I have pain. So what you can start with is identifying what they're already doing. Chances are they're already exercising. If they're not going to the gym, but they're probably going shopping, they may be going to the grocery store, they may be walking in from the parking lot and climbing some stairs to get to their office. They may be going to the mailbox or whatever. Have them count what they're already doing. Now you don't have to start exercising. They're already exercising. You just have to up the ante a little bit each day, very gradually, to get them doing more than what they're doing. So it kind of helps to overcome some of that inertia, some of that barrier to motivation to get people exercising. And then pacing is a good way to help with fatigue. The idea here is that you can pace either by the activity or you can time-based pace folks. The people who engage in pacing, again, this is a hard one to get people to start with, but people who do engage in pacing many times report they get more done at the end of the day, even though it takes a little bit longer, but they don't have a flare-up. And so they haven't been laid out in the bed midday. They've been able to work throughout the entire day, even though it took a little bit longer. And then problem solving and goal setting, these are all things that you probably want to be able to do and work with folks on very early in the treatment process to help people identify what it is. How do they know when they're being adequately treated? What are their goals for this treatment? It's chronic pain. It's going to be around for a while. How do you know when you're done if you don't set the goals right up front? Sleep is also a good thing for all of us, but it's certainly good in the context of chronic pain. And there's a number of behavioral strategies. There's drugs for sleep, but there's also a lot of things people can do behaviorally to help with sleep. For example, taking advantage of a drop in your core body temperature, for example, as a natural signal to fall asleep. Maybe exercising a little before going to bed, or taking a warm bath, raising your core body temperature, and then when you get out of the bath, your body temperature is going to drop, and that's a natural signal to fall asleep. Taking advantage of patterns and rhythms, having a bedtime, having a wake time, and doing that on a regular basis. It takes about 2 weeks of regular bedtime and wake time to get your body just naturally being willing to fall asleep at a certain time. And then using the environment. We experience pain in ourselves, but we experience pain in some environment, and that may be a work environment or a family environment. And so there's a number of social challenges, whether it's a doctor-patient relationship or the friends and families or employers and coworkers. Usually when you have an acute injury, people come around and support you, and they're very helpful, and they're wanting to be helpful. But then when your pain lasts a while, they become less helpful. They come around less often. And so by the time you're seeing someone with chronic pain, they may be somewhat isolated. Sometimes families can either retreat and be isolating a family member, or sometimes they do the other thing, where they are overly solicitous and they take away all the responsibility. Well, that doesn't help either. because people need to have some responsibilities in order to have some self-esteem, to feel like you're getting something done. So working with families can be incredibly helpful in the context of cognitive behavioral therapy or just self-management. Getting the families on board, because families, again, can play an incredible role in reinforcing the right things, but then not taking away all the responsibility. And then physical challenges. When you have chronic pain, it's just harder to get around in the world. And there's often barriers to physical barriers to doing things. And then when you're making recommendations for someone to pace or to exercise more, sometimes you have to think about the environment that person lives in. They may be a single parent. When you tell someone to go out and exercise each day or take a walk each day, they may not live in a safe neighborhood for doing that. So you have to understand the individual to whom you're making these recommendations and make sure the recommendations can fit into the lifestyle they're going to be trying to realize them in. So everything I just talked to you about is contained in several web-based self-management programs. The first is Fiber Guide. We developed this back in 2002. Fiber Guide obviously was aimed at fibromyalgia, but it contains all the self-management topics that I just mentioned. Many people with chronic pain can benefit from the same self-management strategies other than people with fibromyalgia, and so there's been a call to make these available to other forms of chronic pain. While you could use the Fiber Guide, we've decided to go ahead and update Fiber Guide, and we're now making Pain Guide, which will be coming soon. We're feverishly involved in developing Pain Guide more generically for all forms of chronic pain. This can be done in a self-management format. Pain Guide and Fiber Guide are public-facing, but it can also be used as a foundation for cognitive behavioral therapy. And so we have a Fiber Guide, and we're developing a Pain Guide coach's manual or therapist manual so that the patients can have Pain Guide as their textbook, if you will, or their online textbook. And then the role of the therapist or coach is really more for tailoring it and personalizing it to the individual. So these resources we hope will be available. Fiber Guide's available now, but it's only available on certain platforms. Again, it was developed in 2008. We didn't have good smartphones and things back then. So Pain Guide will be on all different platforms and will be available hopefully by the end of the summer. So the bottom line, pain is not located in a body part. It's created in the brain. It's a perception and needs to be treated not as fixing an injury, but treated as a perception and using the therapeutic tools that treat perceptions. Taking time just to listen to your patient's story is necessary, and it'll be treating some of the affective and social components of pain. And then if you do recommend self-management, whether it's exercise or relaxation or sleep hygiene or whatever, make sure you talk about and ask about it with the same enthusiasm and regularity that you ask about the drugs. Frequently, we always ask about side effects for drugs and how are the drugs working for you, how's your pain going with that. But we forget to ask about the fact, maybe this person started exercising on your recommendation. And they went out and bought shoes and they bought shirts and stuff, and they've been exercising, and you don't ask about it. All you ask about was the drugs. Well, they're going to learn real quick what you think is really important, because they've put some effort into that. So please, make sure self-management is a critical component. As we're seeing with all the federal documents, self-management is where it's at. Make sure you ask about it with the same enthusiasm, and you'll be doing a patient-centric approach to chronic pain. I'm going to stop there. Thank you very much.